Okay, so my name is Veronica Vann. I am the case management supervisor in the addiction medicine clinic. I'm a licensed social worker, and I'll let my colleague introduce herself.
And I'm Asher Sutherland, and I'm one of the case managers that works the addiction medicine team.
Yep, so that's us. So Meredith, you want me to just keep rolling? Okay, I'm gonna keep rolling. So just disclaimer, I apologize for the lack of slides or presentation. I in my personal and professional life, I wing everything. And so that's what we're doing today. We are winging it, and we are talking about case management and the importance of it in an interdisciplinary team, especially when in treatment and substance use disorder. So I'm sure we're all very familiar with SDOH, which is the social determinants of health. And I guess how we'll start it off is what we think is efficient case management and why it's important to treating substance use disorder. And what it looks like for us in our clinic. We are a true representation of an interdisciplinary team. We have different doctors, we have behavioral health, and we have case management. And case management for me equals healthcare. Housing equals healthcare. People being able to eat is healthcare. And fortunately, we work with a lot of all the providers that we do work with. They believe the same thing and the importance of it. So kind of what it looks like for us whenever we first try to determine what their social determinants of health looks like. And that's with housing, that's food insecurity, that's everything from do they even have a couch in their living room, if they even have a living room, are they homeless, what kind of inpatient care do they need, the whole spectrum. And we do an assessment, we do a needs assessment as soon as they come in with an intake. And we ask them those basic things, especially a driver's license, transportation, things like that. And then we kind of go from there and we see what they're willing to work on, because I have learned in my career very early on is that I think somebody, if they're homeless living in a tent, that's the first thing that we need to focus on. And sometimes it's not theirs. It's not the patient's first and primary goal. And so it's really trying to figure out what it is that they want to focus on, that we can actually move forward and help them enter into not only treatment, but also into recovery. I will let Asher kind of tell her what she does whenever she goes in with a patient and what's primary for her in case management.
I've been in this role since January of this year, so I'm going on a year. I think during my time here, I've kind of learned that the best way for me to make the initial contact with the patient coming in is during their first visit. During the first visit, we have a behavioral health intake, which is rather extensive. So if there is an opportunity for me to sit in on that, just so I can kind of get the full background of the patient and kind of know what their needs are and kind of get the ball rolling on working with them, trying to meet those needs that they may have. Primarily, we have to work with the patients in order to have them, apply for health insurance, housing, things of that sort. So it's just kind of best for us to make the initial contact on the first visit, just so they know who we are and know that we will be working with them from here on out.
So, and she brings up a good point. So case management, we've seen it all in different, in various settings and medical settings, what that looks like. I would like to hear from one of you guys though, what is your impression of case management, or has been your experience of case management and what they do?
I'll speak on that. They're a very valuable asset to our team, obviously. Like you guys said, housing insecurities, food insecurities. We are a community mental health center, so we get a lot of patients that are homeless or on the verge of homelessness. So case management plays a vital role in what we do with our patients, how we place them, what's the next steps after they're discharged, or even during treatment, in the midst of coming in and maybe losing their housing or their job or whatever it may be, their family support. So I think it's a vital role in our team for sure. And we have some great case managers.
Good to hear. 100%. Thank you for sharing that. Anybody else? Sonia?
If I could, we have a tragic lack of, and understanding of how, like, what a necessity it is for these people to have, all of those, and just be safe, have a safe place to be, instead of down at Jolly Park in the little enclosed slide where you're going to sleep tonight. So when they get out of court for recovery court, most of them do not have appropriate places to go. So having that, and we try to do it all here while we're doing treatment. So when I say gestalt, it is the criminal version of it, like just a couple of people trying to get them on insurance, make sure they've got that. We finally have some recovery homes at another place in town, but oh my gosh, that's like the most, it's almost like the Star Trek version of utopia, is to actually have the money and the services to provide that. Because yeah, it's like, the road to hell's paved with good intentions. And I feel like half my days are full of trying to jackhammer the pavement that other people have laid for things that are not the good stuff for these people to do. So yeah, thank you. And it's so needed.
Yes, ma'am. Yeah. So you bring up a good point. So I know we talked about case management in our clinic specifically, but what you'll see it in different places. I think there is we're trying to go in the right direction, especially in the justice system, and seeing the need for behavioral health and for case management. But you don't, like Sonia said, that you just don't see a lot of it in where it's needed, in the abundance that it's needed. It's very beneficial, because in order for I'll speak on my clinic. I think our doctors will say the same thing, that in order for them to do their job effectively, they need to make sure that their patient is safe. They need to make sure that their patient is going home and able to even access the medical treatment that they need, to be able to even go to the pharmacy to even pick things up. There's so many little things and factors that I didn't even take into account until I actually meet with the patient and I hear about the barriers. So that's what case management really embodies, is how do we break the barriers that nobody else thinks about, because there are so many, and I'm talking little things. We talk about, so for example, getting a driver's license back. What does that entail? Oh, money, right? Okay, well, this person doesn't have employment. It's like this big, so it's okay, well, we fix this, but then we got to fix this and this, just to come full circle back to getting that driver's license. One patient we have in particular has the money to be able to pay a reinstatement fee, but does not have but she is waiting on disability in order to have monthly income to pay for the interlock device that she has to pay monthly for in order to drive and get her driver's license back. So it's very, it's not black and white. Nothing is in substance use treatment, but especially in case management, there's so many little spider webs that we have to make sure each one of them connects, or we take care of, or the crack just keeps getting bigger and deeper. Right now, there are a lot of resources out here. We hear so much about community resources, but I will tell you, and this is just my PSA, between a good case manager and a not so great case manager. If you are working with one and they have a resource list and they hand it to your client, and that's all they do, you're not working with a great case manager. One thing about a resource list, I can tell you, whenever I came into this position, I have about 3 or 4 binders. I mean, thick binders of nothing but resources. I went through one of them one year whenever I was a student, and maybe 5% of that was still active. And so you can't, so what I'm saying is everything is ever changing. Grants run out. Money runs out, resources are done, things aren't doing what they were doing 5 years ago anymore. Churches aren't doing it anymore, but providing food. Times have changed. So case management, and Asher, I think, can speak on this. You have to stay on top daily of what's opened and what's not open. Do you have any experience with that?
All the time. I mean, especially if it is for housing, because we all know the market is insane right now. And it's hard for somebody with a 2-income household to even find a house, let alone somebody with no income to find something feasible for them. So it's just having to stay on top of it with them like she said, daily, just to ensure that they are taking the proper steps, they are using the resources we have given. We are doing our part in calling and making sure they are on these wait lists and trying to see what we can do to get them pushed up, things like that. And then I think one of the other issues that we have come by is most of the patients we see have been to other clinics and have seen other case managers. So they often get a bad taste in their mouth about who we are, because sometimes the case managers are very overworked and cannot provide the adequate care and attention that they need to these patients. So they kind of have slipped through the cracks. So after years of going through different clinics and things like that, they come to us and we are at this point able to meet with them almost every week or every appointment when they come in, and to continue to work on their needs and reassess them after 6 months to make sure nothing new has come up.
Yeah, and at every level, you know, we really at the therapy level, the behavioral health level, the medical level, we even case management, even though it sounds so we're just connecting the dots, it is a teaching moment for those patients as well, because we're trying to teach them how to do these things for themselves. So also what a good case manager will do will not just do it for them, because I've made that mistake before where I'm like, well, I'm just going to get it done. I'm going to do it for them. And then here we are a year later and they still don't know how to fill out an application because I did it for them, and nothing, and the continuity isn't there. They're not continuously staying with the job because they don't know how to interact when they get a W-2 form, you know, or a W-9 form, excuse me, anything. So we try to stay very mindful that it's not just about filling out papers and making phone calls, that we're sitting there connecting with these clients and hearing about what's going on in their life as far as with their use, and how their use is a barrier to them filling out the application, their fear of rejection of why they don't want to apply for a driver's license, or their fear of getting all their criminal records expunged because they don't want to be judged. Some of the stuff that we do is just support. We walk into the courthouse with them so they can face that fear on their own. So, but they're not on their own, they're with us, but they can do it as an adult. And so case management is a very broad thing, and we get the pleasure, we get to be able to meet them not only exactly where they are, but to help guide them and navigate them where they need to be, and to give them the confidence. So that's a big thing that we do. Also, we sling furniture. We do a lot of different things. We are not all case managers are like us, and I don't know if that's a good or a bad thing, but because I don't know if one day we'll have to file workman's comp, but you know, we because there's a lot of people that don't have support, and so we're kind of it. And so when they say, hey, I don't have somebody to help me pick up this couch and move it into my home, or my children's beds need moved, like, we'll do it. You know, we try to eliminate really every barrier that we possibly can. So yeah, whenever you go out there, if you're working with case management, you already have a great team, that's amazing. But if you see case managers that just tell the client to make a phone call and you don't hear them ask, hey, do you want me to make that phone call with you? You know, that kind of support and the follow through is important. So but with all of that, we're going to present a case that we had that was a pretty difficult case management client. And can I share my screen, Meredith? Will it let me? Yes, it will. Perfect. And I'm going to let Dr. Osborne just introduce this patient because he worked with him, and then Asher will take it from there. And
Veronica, would
Yes.
you mind to say what it takes for someone to become a case manager also? So the process, if it's not taking too much time.
Oh no, it takes tiger's blood. That's what you need. Yeah, I'm just kidding. So nine times out of 10, you have to at least have your undergraduate. You have to have an either a human services degree or a social workers degree. There's a lot of places, though, unfortunately, that do hire case management with you don't really have to have any experience. They are just anybody willing to fill that position and be a case manager. Unfortunately, also you have a lot of people being called social workers, and they're really not supposed to, because they don't have the degree, and we have role protection. But 9 times out of 10, if you want a case manager, you have either a social worker or somebody with a human services degree. Yeah. So, and then I will share my screen. All right, Caleb, take it away.
Okay. All right. So this is well, at this point, he's a 46-year-old male. When he came to us, I believe he was 45. He came in with opioid use disorder, stimulant use disorder. Those were his primary use disorders at the time, but he had a long-standing history with multiple other substances, long history of tobacco use, benzo use disorder as well, cannabis use. So he was, if I remember correctly, and Veronica, you may have to correct me on this, I believe he was just a walk-in, or he may have been sent by the day center. The day center, okay. So he was from our day center here, where he was getting some case management services. So he came to us just because he was desperate and he was over it, and the day center had sent him here. He was currently unsheltered homeless. He had a really hard time hanging on to his possessions due to that. And so he had lost transportation a couple times. He would get a bicycle, then the bicycle would get stolen. And that was an ongoing issue for him. He did have recent justice involvement. I don't recall the specifics of that. But I believe he was on probation as well. And he did come to us and relatively quickly mentioned going to an inpatient facility. And so he was here only for a handful of visits, for medical visits. He saw Dr. Troxler once, he saw me once or twice, he saw one of the fellows. By and large, the bulk of the work that was done for this patient was done by our case managers. And so from an opioid, there wasn't a ton that we did for him medically. We treated his opioid use disorder with buprenorphine. He did have, due to his ongoing IV use, he did have one pretty gnarly little wrist abscess. And so we treated that while he was here. It had resolved by the time he left. But basically, we followed up with him for a handful of visits, and the case managers put in a lot of work to get him to an inpatient facility. And so we have not seen him in quite some time. He went to an inpatient facility that's several hours away, and I believe it was his goal. He had some history there, and I think that's where he wanted to be longer term. And so he has not been back to the Tri-Cities area since then. But medically, that's about it. It wasn't an overly complex case, other than the fact he had, all of the use disorders. But really, the work that went into it was primarily case management. So I'll let Veronica and Asher tell you about that part of it.
Thank you, Dr. Osborne. So before we say in detail kind of what we put into this patient, I'm just curious, from a case management perspective, what would be the most effective course of action to help him? Where would you guys start? What do you think where you should start?
What did he ask for? What was the first thing he asked for, or did he ask for anything?
He just came in really asking for help. The very first thing, just that he needs to get off of drugs. That's exactly what he said.
Okay, thank you.
So it doesn't even have to be from a case management perspective. I mean, from medical, therapeutic, whatever. What would you guys first feel like you need to address?
I would probably, excuse me, encourage him to go to our detox center if that happened here, and start there, and then try to motivate him to get into a treatment program, for housing purposes as well as recovery purposes.
What barriers do you think that that maybe he expressed to us that of why he couldn't go to a treatment? What have you maybe seen in your clinic of a homeless person that chooses not to or finds it difficult to go?
Their belongings, we've stored them here at the clinic a few times, and transportation. I can't leave my truck. It's parked here. I can't, it might get repoed or it might get stolen, then I won't have transportation. We really try hard. We've picked up people's cars. We've, taken them into the detox unit a few times. We kind of cowboy it and wing it ourselves around here as well. So.
All right, we are cut from the same cloth. I was
I
about
can
to
relate.
say. I love it. Thank you so much for sharing that.
Absolutely.
Anybody else? Okay, Asher, you want to kind of start where we started with him?
So this was probably one of my first rather difficult cases that I had kind of encountered while being with the addiction medicine facility. This patient came to us with absolutely nothing other than what he had on his body, anything in his pockets, and his bike that he would park inside of the waiting room because he was so terrified that it was going to get stolen, just being outside for X amount of time that it took for him to be seen, get back out the door. The first time he came in, just very hopeless, no expression, didn't see the light at the end of the tunnel. I didn't think that he was worth anything, that he kind of chose this path, and he had an extent of sobriety for a certain point of time, and then obviously things happened, life happened, and he returned to use. So the first thing that we kind of worked with was honestly a phone, because we needed a way to get in contact with him, and if we were going to go the treatment route, he obviously needed to have a phone to contact the treatment and have them contact him and whatever else to get the intake process taken care of. He had come in, we had the phone taken care of, but I think after a couple of visits he had lost it again, or it was broken. That's kind of the story that we had heard. Anytime he came in, he was just expressing that he didn't want to be a burden, that he honestly didn't feel that he deserved to be helped because he had been in this situation for a rather long time. So we kind of played around with the idea of seeking treatment, going through a 28-day stay. Wasn't the first thought on his mind, but after kind of walking through and doing the cost benefit analysis and looking at the pros and cons of him seeking treatment, he decided yes, this is the route for me to take.
And I'm sorry, Asher, but a big thing of why he didn't want to go to treatment at first, he was using fentanyl and he had extreme pain. He had a lot of stuff going on with him physically. And even though he said, hey, I'm sleeping on concrete, and I know that doesn't help much, I'm scared that just the buprenorphine's not going to help my pain. So that was also a big driver into not going to treatment right away.
That, and he had been to treatment before. He had gone to some of the local facilities that we have, and he might have even gone outside of the town as well. He just didn't have the best experience with those places, or wasn't able to stay the full amount of time due to various reasons. So he was pretty ambivalent, honestly, when we first started talking about treatment. But at this point, just kind of where he was then, there was a lot that I didn't think that we were going to be able to have for him, just because he had nothing. So the first thought we had was to have him work towards his sobriety. And the biggest barrier we came across was whenever he did decide to seek treatment, was getting him there, because he did not have insurance, and so insurance wasn't able to pay for him to get from here to Knoxville and out to Clarksville, because from here that's about 5 hours. So we had to take the steps that we needed to take to have somebody graciously drive him down there. And you can talk on that because that was your.
Okay, so so first of all, too, if anybody's experienced a client that is experiencing homelessness, and then getting them to even their medical facility that is within a 10-mile radius is often hard as well. So we started working with him. There was a lot of just catching him as he goes, and we're not a walk-in clinic, but you have to make exceptions with some clients. And he would walk into clinic, he would walk in, he would just disappear, and then he'd come back, and it was because he was incarcerated for 30 days. We had set up, I guess, maybe 2 different times of him meeting me at the clinic at a certain time for a ride to pick him up, to take him to treatment. And he no-showed those couple of times, but he kept coming back. And that was a big thing, is that he had that hopelessness of, I don't want to be a burden. But even when he came in, when he didn't show up, we still reassured him that that was okay, that we're still here and we're ready for it whenever he's ready. So yeah, transportation was the biggest one. Especially the barrier of not having treatment facilities, a lot of them locally or around here, even with 100-mile radius, of keeping them on their medically assisted treatment for the duration that they are there. There is a severe lack of, so especially one that is grant-based. So we finally found one that would take him, and of course that's Buffalo Valley. And we made the phone call. He was able to get a bed date, but there was another big gap in services is that the gray bus stations have now shut down most of their stations due to the city or wherever not wanting the bus station. So literally the only bus station that was closed for us was about a 45-minute drive in Mossheim, Tennessee. And it was, so we were able to get donations, just scurrying around, finding people to fund a bus ticket, but then trying to find how he was going to get to the bus stop. And the literal bus stop was a bench at a Quick Mart. And so there's a barrier right there, is you have somebody that has substance use disorder, can't get them there. Then we do get them there, and then it is a literal bench with no support or anywhere around them, as far as just even a building structure in case it rained or anything like that, for them to wait, because he would probably have to wait for a few hours until the bus could come. He waited, I think, for 4 hours for the bus to get there, because the ride that I had reached out to my local anti-drug coalitions, and we were able to get a peer to come and pick him up and take him to the bus stop. And so again, all of these little barriers that nobody thinks about, and I was like, okay, we just need to get him there. So then the next barrier was that bus doesn't go all the way to Clarksville, it only goes to Knoxville. And so they go to Knoxville, and guess what? The bus is, it's another just little bench in the middle of Knoxville where Drug City is. And so you're taking somebody there by himself, no phone or anything. And I have to try to coordinate somebody to be there at 1 o'clock in the morning to pick him up, to drive him the other 4.5 hours. And even though Buffalo Valley has transportation and has their own vans to pick them up, it's only between an 8 a.m. and noon time frame. These bus routes only run at 5:30 in the evening. So I had to figure that barrier out. And I think we as a team, we did really well. And I was taking care of how he was going to get from A to B, and Asher was going to do B to C, and really getting everybody on the same page. So all of that to say is we found another, we reached out to the other coalition. So I know everybody's hopefully familiar with Inside Alliance or their local regions of the recovery resources. And if you don't know, dial 211. That might be a question. 211 is your resource line. But I just reached out to Knox County, and I said, hey, this is my situation. And people are fearful, I think, to ask what they need, like to call people. I had, you can't have any fear as a case manager. You just ask, even if it's wild, even if it is a wild ask. And I'll tell you, I've gotten a lot of places with it. I've gotten a lot of no's and crazy looks, but we've gotten a lot of places with it. And so we were able to find some random recovery center that I've never heard of in my life that has just started up. And she was willing to come and pick him up at 1 o'clock in the morning and take him there. And so, yeah, so we got him there. And the beautiful thing is that he has messaged us pictures months after of him healthy, happy, working, has a job. He had one return to use whenever he left after the 90 days, and he went working. But the beautiful thing is, as soon as it happened, he knew where to go. He called Buffalo Valley himself and got himself back in, and he called me just to tell me that. He's like, hey, I don't need your help this time. I already did it, but I wanted to let you know what's happening. So that was a pretty intense case for us. But luckily, and not all the time you see it come full circle. Oh, and when he got there, he needed a way to get to work. And he wanted me to try to pack, because I had his bike. So my garage is a storage unit. And we had his bike still with his consent, and he wanted me to send it. And so that's a barrier too. You can't really send things for cheap, especially bikes. So we figured out, we got a bunch of donations, and we were able to deliver him a bicycle so he could work where he was. And that was just the community coming together. Again, you ask the community what kind of resources they have, and you find them, and people figure it out. So yeah, that is our case that we wanted to present. I know we still have a little bit of time left over, but any comments, questions, anything like that? Did you have anything else to add?
No, it was kind of a lot. So if you have any questions.
It was a lot. That was a lot. So sorry, guys.
It sounds like you guys did some amazing work, and very appreciative of that. I want to ask if there was any consideration for trying to access behavioral health safety net funding for transportation.
Well, just like she said, what is that? We've never heard of it, so that would help.
Okay, well, I'll be happy to educate as best I can. So the behavioral health safety net is basically a sort of insurance plan for the uninsured in Tennessee. It's for those who are up to 138% of the federal poverty line, and it is Department of Mental Health funded services. So there's a set of contract providers. So out in your area, I'd have to go back and look to see who that is. It's probably Frontier, I'm guessing, or somewhere there. And I'm going to try to find a flyer to drop real quick. But they provide a range of funding. Now, there is a much richer set of safety net funding for on the mental health side of things versus the substance use disorder. But it still is there. And I know the commissioner is working on getting more funding. They allow for billing for transportation. It was added, I think, in 2019 to that. By those who are contracted to draw those funds down. And it's flexible, but it also has to be aligned with someone getting an appointment from a behavioral health safety net provider. So Buffalo Valley likely is not one of those providers, but I'm just curious about, hey, can we connect with somebody who is behavioral safety net provider to get them into an area and find a way to move them forward. So just something to consider. That's probably not the primary service provided, but we definitely want to know, because it's mental health and addiction recovery services provided at no cost if they can get enrolled.
I'm glad you brought that up. I have a lot of patients that are on safety net, and I had no idea that there was transportation availability with that. So I'm really glad to hear that. I know a couple of patients that could definitely benefit from it. Fortunately, with the SOAR grant that I work a lot with here, they help with transportation up to a certain amount. And so most of the time when they come for their substance use appointment, we just treat everything while they're here. So, but they only do it for a certain amount of months. And then that is nice to know that the safety net can help with that too, because we have a lot of patients that struggle to get here. Thank you so much for
Sure.
that.
And since you guys are a safety net provider, then that you should be able to access it. And I sent the provider manual link there, which has the details. Honestly, if you just do a Control F, or if you're on a Mac, I forgot what that is, but find the word transportation, you can see where it goes. And it's got some limitations. I think it's only up to 5% of total funds that you guys spend can be used for transportation. There's certain limitations, but it's got the codes and everything you'll need in there.
Perfect. Thank you so much.
We have a resource online as well for our attendees. I'll send the link out for that, but I'll add those PDFs to that resource area as well.
My question is, what is the role that your, I don't know, I know how it works differently, with your case management, whether your client, but obviously they went to a treatment center. Can you just explain to us, what is your role when that person now has left your care, gone to an inpatient residential treatment center somewhere well across the state, in terms of the longer term housing and employment solutions that that person may have? I guess, where does it start and end, and where does someone else pick up?
So that is a great question, and that is something that I am actively working on trying to answer better. There is a severe lack of communication between different treatment facilities. I attempt to my thought process, and what I attempt to do whenever they leave is I would like to at least follow them for, I say 90 days, but God, he's been away from us for more than that, and I still follow up with him. But is to at least communicate with the case management, I always tell them whenever they're going to another treatment facility, please put me on your HIPAA paperwork, put me on the release so I can talk on your behalf, or I can talk about you, because what we see so often is exactly what you're saying, that, our vision is, okay, they need 28 days and then they're going to be able to be healthy enough to get some sort of housing or the transitional housing after inpatient, and then get into transitional housing and be introduced to the community and get employment. But what that takes is also facilitation from other case managers and facilitation from the other treatment facilities. It's hard for me to do it over here whenever I have my patients that are still here and he's, clear across the state. But it can be done in conjunction with the other team. And so I have had, unfortunately, ideally it's exactly how I just said. Ideally it would go bam, bam, bam. Me and the case manager, we're homies, we're communicating, we're talking on levels of that they have the same concern for that patient and what's going to happen after they leave their 28-day facility. But it's just not there. And I don't think it's there because of lack of care. It's probably just so much caseload right in front of them, and it slips people's minds, or at least that's what I tell myself. I try to show grace, but it has been very hard for me because there's been a lot of resistance. And sometimes I think it's because I think I'm trying to step on toes when I'm not. I'm just trying to look at, just the continuity of care with that certain patient. So ideally, I want to follow up at least 90 days until they're out, to make sure that they're still doing what their first goal with me was, and that is to get into most likely to get into transitional housing after inpatient. And that's where the ball drops, is right after inpatient. It just, if they say they don't connect with another case manager there very well and think that they're very pushy, they just won't even try to call me. And I've had one facility do that, where it's like, okay, they need to go into an Oxford house or a transitional housing. And the way that case manager pitched it at the end of the 28 days to my previous patient, he was not going for it. It freaked him out. But I was very appreciative of her, because she called me and said, this is how it is. He's wanting just to come home. And I get it, client self-determination, but she gave me a chance to talk to him again, where I had that initial rapport. So I hope that answered your question. That was kind of a lot, but.
I appreciate that. I know it's complicated, and I think I'll be honest. It's trying to see where the parallels are and are not from the on the emergency mental health side of things, psychiatric side. We're frankly just seeing and observing just a complete lack of addressing the housing issues that folks have, and certainly the coordination of care issue you mentioned. In some cases is non-existent, and what should be obvious sharing of records just is people request and they don't get it, or they just don't even take the time. And we're doing the same thing over and over again that's not working, and trying to figure out how can we help somebody. So I certainly think it's appropriate. And I do also appreciate you mentioning self-determination. It's really important. And as you go geographically into different areas and communities, there's going to be more accessibility for things that might be more housing first oriented for folks that may be only interested in that. Which is a
Right.
huge, important piece of the puzzle to have. And understanding what all these things are in every part of the state would be nearly impossible for case managers. So I appreciate your efforts to work together. And I think we have some ways to work to try to continue on that. So thanks for everything you're doing.
I appreciate that. You too. Thank you.
I just want to also mention that we do have a pattern of the network in this country that does really follow the patient, and it's not that much hard for the providers or the staff that they are working in a case to make sure that the patient can be followed to the point that the recovery takes place and all those stuff. But unfortunately, that kind of the network doesn't exist for everyone. That kind of the coverage does not exist for everyone. And I think one thing that we can do as the providers, as the staff that they are working on this kind of the situation, is to advocate for the higher level of the, those legislative people that they are in charge of the, making it easier. Yeah, I know that they made the opioid epidemic as a, big problem in this country many years ago, and they put some funding for that, but also they didn't know from the get-go what is the best way to go and treat the patient. And so the networks exist. For example, I work in a VA, in the same time I work in a ETSU. For me to treat a patient in a veteran affairs system is very simple. Everything is available. Anything I want, I can ask for it. Residential place, social worker help, case management, all this stuff is available to me as a provider to treat the patient. But when it comes to the civilian part, we have a problem here. And that is something we need to advocate so they can, provide the same service that they can provide in this country for a group of the people, which will deserve to be treated like that for all the citizen of this country. So we need to advocate for that kind of the situation.
Taylor, did you have a question? I thought I saw you try to unmute. Now you're muted again. Try one more time. If the audio is being weird, you can also toss it in chat and we can respond that way.
So you can also hold the space button there and it will.
I got it. Okay. Can you hear me now? Okay. I wanted to share a program here in Summertown, Tennessee. You might be way away from where most of you are, but it's they take people from all over Tennessee. It's a faith-based program. It's called the Hope Center Ministries. They have tons of locations all over. But when you're talking about once they go into the treatment, what do they do about housing? What do they do about jobs? Things like that. This specific program, the people that come to it actually live on a ranch. They live out in Summertown, and they actually live there, but it's faith-based. So they have to go to church on Sunday. They have to go to classes during the week. It's different phases, but once they move through the phases, they get to a point where they actually are able to work. Summertown Metals is a business. It's huge here in Summertown, but also in Alabama. And they actually allow the people that are in this program to come work for them. And so they are able to work 40, hours a week full time. But for the first few months, the money goes back to the Hope Center. After they've completed a certain phase, they start getting their own paychecks. So in the beginning, it funds the program, but in the end, they get their money. Once they graduate at different phases of the program, they move out of the house where all the new patients come in, I guess. And once they've reached certain phases, they move to houses that are smaller. So right now, let's say they have 40 in that house. They move to an individual house that maybe has 8 people in it. And all 8 people are at the same level of each other. Once they move out of that, they can actually get a house on their own of just 2 people. So I say all that to say they work with substance abuse of getting them off of those drugs, but they also work with getting them housing. They can keep housing up to 3 years for each individual person. And they also give them jobs. And so these local businesses that partner with this program, they call it volunteering their time, but the business is actually paying it back to the ministry. And after certain, phases completed, like I said, they start getting their own money. But I just wanted to share that. Not a lot of people know about this, and it's a phenomenal program. So if anyone wanted that information, I could definitely put it on here, but it's called the Hope Center Ministries. They provide medical dental. They have someone in Nashville that actually take the people to Nashville to the dentist office to actually cover, any kind of dental work they need. So yeah, I just wanted to share that.
Yeah, thanks so much for sharing that. We have a lot of faith-based stuff around here as well, and they do a lot of good work. So thank you.
Yeah.
Yeah, if you're able to put that in the chat, then we can link it to our resources page so others can.
Okay, perfect.
Oh, that'd be great. Thank you.
Since there's some quiet, selfishly, I have a question that's immediately relevant, and we can follow up afterwards. But have you guys encountered anyone relatively recently that has been trying to access, whether it's an Oxford house or another type of recovery house or any kind of housing, and they have not been accepted simply because of the fact that they are prescribed Suboxone or buprenorphine? If anybody would be willing to share, and I'm just going to share it. There's someone doing it, and we're looking at that. We're trying to uncover these barriers, and we're looking for someone who wants to share their story on those issues. And frankly, I was a little frustrated. I was on a national research and provider call yesterday regarding recovery houses run by the National Association of Recovery Residences, and their founder and other folks were on there. And they just claim that it's a gray area in terms of providing care to folks with buprenorphine. But then I asked them to provide whatever they had documented, and they sent me a report that says very clearly they cannot refuse to accept them based off of this, but they're frankly just dodging the issue a little bit. And ethically, they agree that it's not okay, but legally, they're not willing to go and say it's illegal. So anyway, we have no resources for folks. I keep hearing of people who are denied access to shelters, and even during the winter, simply because they had a bottle that had Suboxone in it. We're not trying to burn our partners. We need these amazing recovery housing partners, but we also need them to help people with disabilities. So I'm going to put my information in the chat, but if anybody is willing to follow up with me after this further, I'd be very interested.
I'll be emailing you.
Okay, thank you.
Am I on?
Yes.
Hey, Veronica, this is your new nurse, Lisa. I hate public speaking, so my voice is going to shake a little bit, but I just wanted to point out the importance of you telling that story. I thought you did a fantastic job, and I just think that narrative is really important in case management. I think in reaching out to those individual people and being able to talk to them and put it in that form, in that story form, is really effective. And I think even on a bigger scale, narrative is important. So you did a fantastic job. And I think that's a talent of yours as a case manager and a really important part of it. That's all.
Oh, thank you, Lisa. I'm so glad you're with us.
Thanks. Yeah, thanks for that as well. Yeah, that was a great case. It gave us a lot to think about. And I love that other people were able to share resources and things that are available, because as Veronica pointed out, that is like you have your list of things and it gets bad as soon as you printed it. And it's hard to keep updating. So if we can share resources, it's amazing. We're just about at time, but if anyone have any final questions, but we will keep having conversations. If people want to keep bringing resources back every other week, we all value those a lot.